Greetings and welcome, and thank you for being connected from all around the world. My name is Kenneth Ngure. I'm an associate professor and chair Department of Community Health, Jomo Kenyatta University, Kenya. This session will be held completely live and is open either through conference platform or for registered delegates, or at the IAS live stream website for free access. Feel free to send your questions that you may have on our speakers at any time through the Q&A box. For those who are not connected via live stream website, you can also send your questions as well as suggestions you'd like us to address to our IAS educational mailbox by email iasedu@iassociety.org. Thank you, Desmond Tutu Health Foundation, for coordinating this live session for South Africa in collaboration with the IAS Educational Fund. And now to introduce Rita Gail Baker. Professor Rita Gail Baker is the director of the Desmond Tutu HIV Center at the Institute of Infectious Disease and Molecular Medicine, University of Cape Town. And she is also the Chief Research Officer of the Desmond Tutu Health Foundation. She is a physician scientist and infectious disease specialist. Her research interests include programmatic and action research around antiretroviral rollout and TB integration, prevention of HIV in women, youth, and MSM. Baker has also recently been involved in a number of COVID-19 trials and co-leads Sisonke phase 3B, which has seen vaccination of over 500,000 health workers in South Africa. She has led numerous investigator-driven studies in HIV treatment, prevention, and tuberculosis. She is a past president of the International AIDS Society and served as the international co-chair of the 9th IAS Conference and the 22nd International AIDS Conference, and co-chaired the Research for Prevention Conference that was held in January 2021. Please go ahead, Rita Gail.
Well, thank you so much, Ken, and it's always a pleasure to co-lead a panel with you. And I just want to make everyone aware that, of course, Ken is a member of the Governing Council of the International AIDS Society and your African representative. So for those of you who are joining from this region, Kenneth Ngura is your man. And on that note, I want to point out that this session builds on the work of the International AIDS Society Educational Fund, and thank Lauren and the whole team for their hard work in putting these meetings together. There were a series in the Southern African region in the last while, and importantly, on the 25th and the 26th of March earlier this year, we had a wonderful two-day session that brought together a number of the people who are on this panel today, as well as other players, to discuss some very important topics. In particular, we focused on pre-exposure prophylaxis for HIV prevention, children's health, specifically on progress towards ending vertical transmission, and mental health within the context of HIV in Southern Africa. On that note, I want to go through a couple of slides of our key conclusions and actionable items. So you should see a slide now that brings to your attention that we had as one of our conclusions that we needed to champion primary prevention going forward. And we recognize that we'll need advocacy, strong visionary leadership, and a supportive policy environment. In addition, we recognize that quality of care is undermined when efforts to strengthen the health system as a whole are not prioritized. And this leads us to the conclusion around the integration of services, including sexual reproductive health and mental health services along the HIV cascade, both in health facilities and community settings. And of course, HIV-related stigma still 40 years on, very much with us, both external and internalized, continues to exert a negative effect on the health outcomes and well-being of people living with HIV. And we need mental health support where possible. And then finally, if we are to re-engage people in the HIV narrative, we need new messaging distributed in new ways and into new populations, including, for example, cisgender men in this part of the world. Next slide, please. These were some of the actionable items that we raised, and we hope you will take these to heart and actually become champions in your own region. First of all, we need to develop a package of integrated services for people who live with HIV that include mental health, and that is tailored to the end user. Community-based and community-led services are needed, and we need to scale these up within our community spaces. We need to move engagement into action. There's no good use just having words without deeds. So revitalization of engagement is needed to move us towards increasing uptake and implementation of a range of pharmacological, psychological, and virtual tools. And we need to look to the future and prepare now for the availability of long-acting agents for treatment and prevention. And of course, get our health systems ready for this. We also need to get granular about data, promote and track the use of evidence-based interventions, and build stronger healthcare systems, including increased care and support for healthcare workers themselves, particularly in this time of COVID. And finally, very importantly, to have a patient-centered, client-centered empowerment agenda. So thank you for those slides. It is now my pleasure to introduce you to the panel. And of course, we will move through these three main topics in the next 50 odd minutes. So let me first introduce to you Tengetile Dlamini, who's a researcher at the National Emergency Response Council on HIV and AIDS, or NURTURE, in the Kingdom of Eswatini. Duncan Moketsi is here today representing GNP Plus from South Africa. He's recently been part of the advisory group for Y Plus in South Africa. He's a dedicated youth representative. Ellen Mubanga is joining us as a representative of the National AIDS Council from Zambia. She's passionate about HIV prevention and a strong advocate for PrEP implementation. Charisma Mushi is a social worker at REPSI in the United Republic of Tanzania. She is in charge of furthering the Ready Plus program in Tanzania and seeing the day-to-day work of that program. Professor Amina Goga is a great friend and a unit director at the South African Medical Research Council, HIV Prevention Research Unit in South Africa. Amina is a pediatrician with a PhD from the University of Pretoria and is passionate about the elimination of mother-to-child transmission. And then finally, welcome Danielle Treville, who is a research clinician at Wits Reproductive Health and Wits Institute and the HIV Institute in South Africa. She also is an implementer, a public health specialist, and very passionate about PrEP and other programs. So welcome, panelists. An honor to have you here. I know you contributed greatly to our previous two-day meeting, and we look forward to your remarks today. So the way we're going to do this is we have divvied up the panel into three sections. We'll start with PrEP and HIV prevention, and we're going to do this by starting with a poll. So you should all now see a poll on your screens. And the first question is really about men and PrEP. Do you think men should be included only through the messaging around PrEP, be offered PrEP with their partners, or not be involved in messaging at all for the sake of discretion? In other words, we should only be offering PrEP to young women and girls, and we should avoid men. So please now place your best choices, and also please be thinking about questions. Pose your questions in the Q&A section, and we'll be picking up those questions in order to be able to pose your questions real time to this wonderful group of panelists. Okay, so we have a poll that shows a few thinking that men should only be involved in messaging, but overwhelmingly the vast majority think that PrEP should be offered with their partners. So wonderful. I'm delighted to have that response. And I'm going to start with some questions while we wait for other questions to come to the panel. I'm going to start by asking, maybe starting with you, Danielle, what do you think are some of the biggest barriers still existing in the scale up of PrEP in this part of the world?
Hi, good morning, everyone. Thank you so much, Kenneth and Linda Gale, for having us here today. So I think it's important to acknowledge that there definitely are ongoing barriers in the PrEP rollout, and I think we need to think of this kind of from big picture all the way down to the individual. I think we need to create a policy framework and a kind of wide-scale rollout and remove as many barriers as possible for people wanting to access PrEP. And so that requires the removal of the bureaucracy at an implementation level as well. Make this program as simple as possible so that people are able to access it if they want it and where they want it. In addition to kind of simplifying the program, we want to make sure that we have specialized service available that are comprehensive and address all individuals' needs, particularly vulnerable populations. And so offering core comprehensive services that are acceptable and accessible is incredibly important. And that, together with that, goes the kind of capacity building and training of healthcare workers. We need to make sure that healthcare workers are equipped with to address the needs of vulnerable populations and kind of create a welcoming environment within our healthcare sector. Having said that, I think we also need to acknowledge, and I think we're seeing this happen rapidly with COVID, but we've been seeing this happening over the years with HIV treatment and prevention, is that we need to acknowledge that the healthcare system needs to expand, and we need to diversify the way in which we provide these services to people so that they can access them in ways that are most appropriate for them. So having multiple models available and integrating HIV prevention services with other services has been shown to be effective and feasible. And so we should be both simplifying the PrEP rollout, making it accessible for everyone who wants it, but also providing specialized services so that people feel comfortable accessing service.
Great. Thanks, Danielle. I think that was really comprehensive. Ken, do you have any more questions? I know PrEP is very close to your heart as well.
Yes, thank you, Rita again. So I just want to ask, how should our tailored messaging be updated to encourage PrEP use?
And maybe we can pose that question to, what about you, Ellen? What do you think about tailored messaging?
Thank you. Yes, how should we tell our message or the tailored messaging? Definitely looking at the barriers that have been highlighted, and also to add on that in this part of the world, one of the key barriers also is the fact that we have low risk perception at the moment. And therefore our messaging should be able to bring out message that allows people to check their mindsets, to check their behavior, to check their risk perception, to acknowledge that all of us are at risk of contracting HIV. So the message should be tailored, one, to a target population. Two, it should be tailored to bringing out the risk perceptions that it is risky, and also to the message should be tailored to removing or destigmatizing PrEP from the communities, because that too continues to be a barrier. So the barriers, the messages must be tailored towards answering the barriers that are still existing in terms of scale up for HIV use of prevention using PrEP. Thank you.
Thanks, Ellen. Maybe so, Duncan, I was pleased to see that people agreed that the partners of PrEP users, young women and girls, should also be included. What are your thoughts about that? What do you would you like to expand on that? How do we engage men better in PrEP programs?
Thank you very much, Linda Gale. You know what, I think one of the things that, we know that always men, when they have to seek health services, it has always been a problem. And I think the problem is exacerbated by the fact that often they feel that they are excluded. We normally talk to them more as like just subject, like, okay, we have to reach out to men. But I think if we really include them so that they become part of the solution, it will be much more effective, because they would sort of own up to the message, and also, and make sure that not only do they do they take up PrEP for themselves, but they can also be active advocates, and really reach out to other men to make sure that they also take it up. So I think for us to be able to reach out for more men, we should really meaningfully involve them in our messaging, and we have to tailor the messaging so that it is so much appropriate to them, so that they can actually have they can be a bigger buy-in from men.
Thank you. I think that's right. Maybe turning to Tengetile, what about the future is bright? We've got long-acting options coming, both for prevention and treatment. How should we approach that as, as people, maybe both from a policy implementation point of view, but also just getting the health systems right? What are your thoughts?
Thank you very much, Linda. Looking at the future, it is very much important for us to rely on data. We need to base all our interventions on evidence. So in order for us to look forward, we need to have researches that are in place. And one other thing is that even if we have those researches, we need to be able to disseminate that data at all levels, not to the programmers, not to the service providers, but also to the beneficiaries, the people that we are targeting, and then make sure that we simplify the results into the messages that they have talked about. And also, when I want to add that we bring our findings such that if we do the messaging, we do the targeting, but also so that some other people may not feel that they are left behind. It's also only for the key population. We also find a way to bring our messages such that even the other populations are included, and also promote the issue of integrating those results into the other sectors that are there in our HIV response. You'll remember that our HIV is multi-sectoral. We want the information to be understood by the people in the other sectors, because if you look at stigma, it affects all of us. And then the people that are in the Ministry of Agriculture must understand what are the issues that are faced by the people in the HIV response. The people that are in economic empowerment must understand. So when we look at the future, we must then have research and base our programming, base our activities, our interventions on evidence, and then be able to bring that information back to the people in a way that they will understand, touching a number of areas and elements of their lives, other than just saying we want to do prevention, and yet we want to prevent HIV amongst people that have got other underlying factors that needs to be tackled. Thank you.
Thanks. Ken, what about you?
Thank you, Rita Gail. This question I'll shoot it to Amina, and just to ask her to comment around pregnant women and PrEP use, because we know that pregnancy increases the risk of HIV acquisition. What would you want the audience to know about PrEP and pregnancy and pregnant women?
Thanks, Ken, and thanks for the question. I think pregnant women and even lactating women are really a key population for PrEP use. And I want to talk about two things. One is the broad policy level, because what we've seen is that although PrEP use is part of policy in some countries, others have not included it for pregnant women and lactating women. And I think that's really an area that needs to be focused on now. And secondly, for those countries that do have it as part of their policies, implementation is a real challenge. So I think it then burns down to the same issues of how do you tailor key messages. From some of the work that we've done, what we found is that there's still very limited knowledge and awareness about PrEP use during pregnancy and lactation. And the fear is on two levels, one from women themselves and the second from healthcare providers. And so it's important to look at these two groups of people to make sure that the messaging is so positive that we clarify any hesitancy. We provide people with data, safety data, and then we move forward to implementation. And in terms of implementation, you know, for pregnant and breastfeeding women, you do have a captive population and you have designated visits during antenatal care and postnatal care. And I think the real issue is to integrate PrEP use into these visits as well, to not forget about the partner. I think too often we find that women who have just had babies or who are pregnant describe themselves as being single or don't bring their partners in, or their partners are not included. So make sure that they are included. And I also agree with the idea of making PrEP available at easy to access outlets. You know, we should have a system for sure, but let's make it accessible. And so I think we need to concentrate on pregnant and breastfeeding women. The majority of women don't know or are not aware, or the majority of men are not aware that PrEP can be used in this population. And so much work needs to be done at that level. And for those who are on PrEP, I think the challenge is to make sure that they do take it and that they're adherent. And I think that's where, you know, the long actings will be very useful, because it's one less thing for pregnant and lactating women to worry about. Maybe I'll stop there. Yeah.
Thanks, Amina. I think really lots of food for thought. And I know we could devote a whole hour to PrEP and prevention, but we're moving along. And so thanks, everyone. And just noting Anna Grimsrud's comment that men in their own right should be offered PrEP. And so I do, the idea of the poll was to be somewhat provocative, but I absolutely would agree with you that we need to think about PrEP for men as well. Tengetile, I see your hand, but I'm going to ask you to hold on to it just in the interest of time and maybe weave it into the next section as well, because we're now turning to children's health and ending eradicating mother-to-child transmission, or vertical transmission as we prefer to refer to it these days. So let's turn to our second poll. Again, this is your chance to give your inputs. And the poll suggests that elimination of vertical transmission is only possible when countries include such plans in national HIV/AIDS programs, when adequate resources are made available at country and international level, when testing is included at multiple time points in antenatal and postnatal care periods, and when prevention of mother-to-child programs include integrated services such as sexual reproductive health services, e.g. contraception, STI screening, etc., or finally, all of the above. So please go ahead and go with your polls now. And we ask you again to remember to post any questions to this expert panel as you wish. Okay, so we have, perhaps not unexpectedly, I know we've been dealing with this problem, sadly, for many decades. We're not yet at elimination, but 89% of people feel that all of the above. We had a 5% saying that we needed to have these elimination plans in our national program. So I'm going to ask Ken to start us off with some questions.
Thank you, Rita Gail, and I'll open this to any of the panelists to chime in. Well, the specific question is, what are the biggest remaining barriers to ending vertical transmission?
I see Amina nodding. Perhaps Amina wants to pick up.
Yeah, thanks. I think if you look at vertical HIV transmission, much of the transmission nowadays relates to two things. One is incident maternal infections or incident infections during pregnancy or during breastfeeding. And the second one is just having people dropping off antiretroviral use. So those are really the two big things. And as we have become better in antiretroviral use antenatally, breastfeeding is a critical time point. And so just based on that, for me, the whole PrEP discussion is very important, as well as messaging about HIV prevention during pregnancy as well as breastfeeding. And then, support postnatally, because if you look at the way the curves have come down in terms of vertical transmission, antenatal and intrapartum transmission has come down considerably, but the remainder of vertical infections do occur now during breastfeeding. So that's such a critical time point. And I think we need to be looking at additional interventions that can be implemented at the point of delivery. So key things for the health system would be repeat testing during pregnancy as well as lactation, doing viral load testing at the point of delivery so that one knows whether you're dealing with a high-risk mother-baby pair or whether mom is virally suppressed. And then postnatal support and postnatal care. And coupled with that, I think we need to be looking long-term, so short-term as well as long-term. Short-term will be, what can we do now to make sure that this mom and baby are on appropriate antiretroviral interventions to reduce mom's viral load as much as possible, and to make sure baby is safe. But in the long term, we need to be looking broader for something more, something like a vaccine kind of intervention or immunoglobulin. And so I think that's the direction we must go in to make it an easy, safe intervention that can be easily integrated into immunization programs even. So maybe I'll stop there for now.
Thanks, Amina. I wondered whether Tengetile wants to pick up on just the, I think Eswatini has made some headway here, but what is the importance of having this in a national program? And how should we encourage the countries in the eastern southern region to really readopt the elimination of mother to child as a priority? Tengetile, your thoughts?
Thank you very much, Linda. Maybe before I get there, I think the other challenge, the main challenge is the emerging pandemics that are taking place, which makes it very difficult for the other countries to come up with or running or pushing the other interventions of the HIV response. But I would like to say that we must learn from what has happened previously to say that focusing in one area, leaving out the other areas. If you can look at the fact that we've pushed treatment and run with treatment, and we are so far with treatment, and we're coming back again now trying to push prevention. So other countries, including Eswatini, must learn that we need to strengthen our health systems such that we're able to run up with all the pandemics, all the epidemics and the pandemics that are facing us at that particular time, so that we can be able to address everything. So it is important, even with our PMTCT and with COVID, and to strengthen our health system, to have our preparedness plans ready in place all the time, so that whatever comes, we are able to address them all together at the same time. But then to come to your question, we would like to encourage every country or state or nation to be able to push the agenda of prevention of mother-to-child transmission, because we are looking at the future. The future is our children. We need to empower them. We need to prevent them. We need to give them all the necessary information that is required for them to be able to take the future to the end. We need to make sure that we have a lot of missed opportunities for testing. We need to make sure that we upscale our HTS. We need to make sure that we look at our program for providing art. We also have to make sure that we look at even the time in which we are returning the results for viral suppression, so that we can make sure that everything is in place. It is important to focus on that so that we are able to do better and be able to take the response to achieving the goals and the targets that we have.
Thanks, Tingatili. I'm going to pick up with Ellen here. You raised the viral load question, and there are two very nice questions I'm going to combine here from the audience. The one is, what about the U equals U messaging? So undetectable equals untransmittable. And what about the role of fathers in this? And are we engaging men in their role as fathers sufficiently? So Ellen, what are your thoughts about those two aspects? So treatment as prevention on the one hand, and then engaging those fathers and partners.
Okay, thank you, Linda. Indeed, engaging the fathers is very, very important. And I think this is what has led us to where we are, in that we have targeted more on addressing the issues and challenges on the mothers, taking the responsibility alone. And along the way, they've not been able to manage it on their own because they face challenges where men are not involved and that men are not supporting the process. And therefore, if we have to win, we have to end vertical transmission, we need the fathers to get involved. From the onset of the whole process of pregnancy, of breastfeeding, of upbringing the child to the point that the child is secure and safe. So we need to have messages that are targeting fathers to take responsibility, to be able to be present in the life of the mothers and the life of their children. So that message must be upscaled, and we need to speak at all levels that fathers must get involved in the life of the mothers and the children. Coming to treatment as prevention, I think looking at the level we have reached in treatment, the results we have gotten, we need to push the agenda of treatment as prevention, because it is one of the game changers that will change the setup. And therefore, we need to ensure that there is adherence in the process, because there are people who are suffering fatigue and they are dropping off, and also because sometimes change of space, they lose out, they fall out. So we need to ensure that our message right now should be everybody who's on treatments must adhere to treatment. And when they adhere to treatment, there must be support mechanisms that will monitor them to ensure that we have viral load suppression. And because we know from science that viral load suppression will mean that we have reduced transmission or zero transmission to the children as well as to any other partner that they may have. So it is important that we stick to the message and we all speak the same language and ensure that there is adherence. And in the community, we must ensure that we are engaging all stakeholders, the religious space, the business space, the adolescent space, the key population space. Everybody must get on board to speak that treatment is a game changer to prevention. Thank you.
So we told you this panel was dynamite, and that just really, I think, underpins it. I'm going to quickly, before we close this section, I'm going to turn to you, Charisma, very quickly to ask, what about integration of sexual reproductive health services in antenatal care? Do you want to just comment about the importance of that?
Thank you, Linda. Sexuality and reproductive health is something, especially in the African context, that has been left behind because talking about the sexuality is a taboo. But it is now time really to wake up, especially for the families and the communities, to start speaking about the sexuality and reproductive health and integrating men in the discussion, because sometimes they are the ones who are taking it behind. And also in terms of in the healthcare system, it is there, but there is a need to put in more emphasis when the mothers are really attending the antenatal clinic, to have ample time to discuss about this, and also to make them that they understand exactly what does it mean, so that they can make a healthy choice of their life, but also to prevent those who are close to them.
Thank you so much. And that closes that section. And moving to our third and final section. And you can see this was really a very rich discussion. We moved to mental health. And let's turn to that poll. It asks you, if you can look at your poll now, and we're honing in on adolescents. Mental health should be screened for in all adolescent health encounters. When adolescents alert the practitioner to a potential problem, when the adolescent is found at emergency units after an event such as parasuicide, or adolescents are generally well and mental health resources should be directed elsewhere. Please go ahead and poll now. Please remember to post your questions as needed. And we have a poll result. And again, perhaps not unexpectedly, 91% of people feel that all adolescent health encounters should receive mental health support. I'm going to turn to Ken to pose the first question to Duncan about this.
Yes, thank you. And interesting to see the poll results. My question specifically is, how can we integrate mental health services into existing settings?
Thank you very much, Kenneth. You know, mental health is actually one of the issues that is still stigmatized in most parts of Africa, especially, you know, as an African person. And now you will find that a lot of people who are living with HIV, for example, they face a whole lot of issues, and mental health is one of them. And it's actually one of the things that is actually left out. So what we need to do is to make sure that we really build on existing structures. You know, I've been listening to most of the panelists, and they've been talking a lot about integration. We know that integration is very important, not only because of it is important for health outcomes, but also because it will actually assist us in terms of reducing the number of maybe hospitalization and people always having to come in and out of health facilities. So what do we need to do is just invest on what we already have. I think HIV response has actually taught us quite a lot, especially around the issue around integration. Yes, it can be costly, but if you look at the long-term benefits of it, it can actually really help us in achieving a greater impact and building on the milestones that we've actually achieved. So now what we need to do is to make sure that we reduce the stigma around mental health, improve the human resource capacity at the health facilities, also recruit mental health staff, and those who are already in the primary healthcare sector, make sure that we they're well supervised, they're given the necessary support that we need, so that we can actually integrate better. So, because it's very, very much important. I remember a couple of years ago, HIV activists, they developed a global advocacy agenda. And the respect for human rights and reduction of stigma and mental health was actually one of the agenda that was actually in the document, but not much was actually. So I think it is about time now that we start making sure that we advocate and ensure that mental health become part of the HIV agenda. Thank you very much.
Thank you.
Danielle, I wondered if you would like to comment just at, how key this aspect is in terms of adherence to, we now have this wonderful sort of array of biomedical interventions, but of course the keystone of all of this is adherence and persistence. Do you want to comment a little bit about the importance of mental health and why this is so important to consider in our broader programs?
Yeah, thank you. I think that's incredibly important. I think the first thing, I think that the term integration often makes everyone a bit nervous, especially healthcare workers. I feel like we think, there's more to do. It's going to be challenging. Wait times are going to increase. And I think the first important thing to remember is that there are different ways to integrate services together, and a one-stop shop is one of those ways of integration, but a good referral system is another way of integrating services. So I think a really core component of that is healthcare worker capacity building, equipping healthcare workers to feel confident in dealing with mental health issues, because as has already been mentioned, kind of stigma is an important component of adherence, but so is internal stigma. And so I think working through what those barriers may be. And we've seen this in the PrEP programs, that when providing a good counseling service, you open up the discussion, you see an improved adherence, access to mental health services can build off that, and really does, especially I think in adolescents and adolescent girls and young women, I think building a system where people are able to speak through where the challenges are, because often we're not really, as healthcare workers, we're not really in tune of what someone's specific challenges may be. And so by having those counseling discussions can really improve some of the barriers to adherence, not all, but many. And so I think having kind of basic mental health screening tools, equipping healthcare providers to be able to have those discussions, and having a good, I think as Tengetile said earlier, having a good foundation in your healthcare system, knowing how to move people through the system effectively is really important.
Yeah, so I wonder if, Charisma, if you want to pick up on this. We know that psychologists, those health experts, are in short supply in this part of the world. How can we practically, provide that kind of mental health support in our programs? What else can we be doing practically at the rock face?
Thank you, Linda. I think from the local context, looking at my experience, there is a need really to look at the health providers themselves, because at the workplace they have stresses, and yet we are expecting them to support the other people with mental health issues. So there is a need really for the system to put in place measures that can support the health providers, especially at the facility level where the clients are getting the services, so that they can be able to provide quality mental health services before they reach to the mental health disorders. But also there is a need to strengthen the social support systems, whereby the clients can get support while they get at the facility level. When they go back to the community, to the household, they get the same support in terms of psychosocial support, so that we can avoid the other problems. And also the issue of stigma and discrimination, it has been mentioned in my colleague there. And also the referral, there's also a need to strengthen the referral system. at all levels, so that we can people can continue to get the quality mental health services. Thank you.
Tengatili, I'm seeing your comment to us here in the chat around peer support and task shifting. Do you want to comment? You have the floor.
Yeah, yes, thank you very much, Linda. Maybe we can just go back a bit and understand that mental health issues, they are broad. They come from a number of factors that are coming up. Some of the issues are in the family, some of the issues are coming from the community, and many other places whereby the issues are coming up affecting the life of a person. And then now you bring the issue of HIV, you bring the issue of all other illnesses or diseases that are coming up and affecting the life of a person. So what I've indicated is that okay, you need to look at the life of that particular person and treat that person as an individual and understand the issues that the person is going through. So in that case, it may be very difficult for the health workers to pay attention to one person at a particular time, because there are many other issues that are coming up into the health facility. Then if we can promote, because it has worked, promoting task shifting and integrating mental health into HIV, it allows the people to get into, especially if they are people living with HIV, they get into the support groups of the people living with HIV, and then they get support there. We have seen quite a number of support groups being able to provide psychosocial support to each other, providing economic support to each other, and our donors has even seen that that model is working, and they've supported, even governments have supported to address some of the underlying factors that results to the mental health disorders. So if we can go back to the communities, use those peer support groups to be able to help the people, and then be able to come up with trainings and empowerment to be able, if we are saying they are addressing issues of economic empowerment, addressing issues of poverty and food security, then we should be able, but what I've left behind is the issue of being able to train those groups now to be able to handle those projects. And then at the end, the projects failed and didn't answer or correct or address the issues that are there at hand to be able to address mental issues of people living with HIV. So in a nutshell, what I'm saying is it cannot be only because, thank you that you have asked the question such that you're saying existing settings. The existing settings have got those structures, economic, food security, and all the stuff. If we can quickly move in and integrate mental health in those structures that are available, we can be able to somehow address the issue of mental health disorders. Thank you.
Thanks, Tengatili. We've had a wonderful recommendation here, and I do want to shout out that the new Journal of International AIDS Society supplement on global mental health and HIV prevention and care is available now. So please look to that resource, I think an important one. And I'm going to ask Amina maybe in the last moment before I hand over to Ken to do a little bit of a sum up of what you've heard in the panel. Maybe just ask Amina, how do we get our healthcare providers to embrace the recognition of the need for mental support and well-being in our HIV programs? Amina, your thoughts on this? I know you are passionate about this as well.
Yeah, thanks. I think it's such an unmeasured disease. And we often think about mental health issues in adults, which is very valid, but I think we need to start thinking about mental health issues in adolescents as well, youth and adolescents, because with what they've been exposed to over the many years, now compounded by their increased exposure to social media, to COVID-19, unrest in various countries, I really think their mental health is suffering and we're not really paying attention to it. And so healthcare providers are often resistant. You know, it's an unmeasured disease. They don't see and it's not measurable directly. And so I think the starting point is to put in place very simple messages, many healthcare providers think they're immune as well. And I think what COVID has particularly shown us, and HIV before, is that none of us are immune. We're all human beings living in a community exposed to everything else that everyone else is exposed to. And so we are targets, and we may have mental health issues as well. And so to start at the very bottom and basics with simple questions, let's simplify and clarify who are we, where are we coming from, what did we experience, and support healthcare workers to start off with so that they can speak about mental health and support mental health positively. So it's almost like we have to backtrack a little bit and take care of them, all of us, so that we can take care of other people as well. Yeah. And it's the only way to do it. Otherwise, we'll have a lost generation, I think, we need 2 generations, ourselves and our children who are youth now.
Thanks, Amina. I think that's beautiful to end on that, and just the importance of self-care generally at this time. I know particularly in this region, we sort of often go from crisis to crisis. South Africa is really hurting at the moment, and recognizing, again, just the need to pay attention to that all-important health and well-being that includes mental health. So thanks again to the panel for extraordinary insights and wonderful thoughts, also terrific questions and inputs from the audience. So thank you for that. I'm going to hand to my very good friend Ngura now to ask him to sum up what he's heard and maybe focus on some actionable points here. Ngura.
Yes, thank you, Rita, again. I think this has been a very interesting session, and we thank all the panelists. And there are many nice things that we've had, and probably we'll do a proper summary after. But just to say, when it comes, for example, to the issues of scaling up PrEP, I've heard a lot about the importance of clear messaging, the importance of including all populations, including men, pregnant women, and breastfeeding women, and the need for innovation so as to reach as many people who need PrEP so that they can not only initiate, but continue with PrEP. On the issue of children and adding vertical transmission, I've had many times across all panelists on the importance of testing, and not only testing, but also repeat testing. So that was one of the key messages in terms of testing. Then there is also in terms of children and adding vertical transmission, and also the issue of U equals U messaging in counseling pregnant HIV positive women. So that is also another key message that I've had, but there are also very many other important things discussed, including the need for policy changes to facilitate the ending of vertical transmission. And then coming to mental health, I want to highlight that there was a lot of issues also discussed there, and probably also across the first 2 themes, there was the need to include men. Probably I forgot to mention that. But then for mental health, there is need to think around issues of ending stigma around mental health, and there is need to include adolescents and look for ways to train health providers and keep them informed on how to address the current challenges. And there are a lot of other innovations around addressing mental health, such as peer-to-peer use of support groups. And probably I will stop there. I know I've touched a bit of things, but I'll also pass to Rita again to also give her impressions.
Yes, thanks, Ngura. I think this is wonderful. Maybe given that we've got a few minutes and we've been so punctual, I'm going to turn back to the panel and say, so give this a thought quickly. Just what do you think is the most important thing that we here in this region need to be focusing on in terms of actionable items? And I'm sure there's a laundry list, but what comes to your mind immediately, just in the next... let's turn, I'm going to ask Amina if you'll start.
Actionable items, I think health system strengthening, but that are community-centered. So just, I think the whole issue of community-centered care. And I think that we fail to do that often. Our care is very kind of institutional, and I think we can do more and get adherence up, increase access to care and uptake if we just start thinking about community-centered care and patient-centered care, and start reframing how we think about healthcare, and then put in place people to help us to do that, you know, peer counselors and people at that level. Yeah.
Great, thanks, Amina. Tengetile, one concept, one word.
Thank you. Thank you, Linda. Sorry. There is a need for a higher, my closing will be saying there is a need for a higher and a robustly designed research to assess and compare integration models at different levels of service delivery in terms of their long-term impact on patient health outcomes and cost effectiveness, especially in the sub-Saharan region, African region, where income is limited and the burden of HIV is high.
Duncan, what about?
I think my two words are going to be accessibility. Let's make the PrEP messaging accessible to the remote and rural communities so that they understand what it is for. Accessibility to the message of you equals to you. It will actually assist us a lot in terms of reducing stigma. Another thing, integration. Let us integrate and make sure that mental health issues become part of the agenda. Thank you.
Ellen?
For me, is to ensure that we continue not to leave anybody behind. We ensure that we target our interventions to all the key necessary populations that need to be part of the process. And that is how we can win. And prevention is key to our winning our battle against HIV. Thank you.
Charisma?
For me, I think there is a need really to put more awareness on the importance of PrEP, but also to advocate for the governments to allocate enough resources for the availability of the PrEPs from all levels, from the national level to the community level.
And final word to Danielle.
Just to be able to provide comprehensive core services that are accessible and acceptable to all population groups, and don't forget about STIs in the mix of everything.
Thanks to a wonderful panel and to all our friends connected here from Mozambique. We are pleased to announce that the next IAS Educational Fund meeting will be held this September 2021 for Mozambique and neighboring countries. To further develop these discussions, please reach out to the IAS Educational Fund team for more information. I want to thank my team and the IAS for this wonderful, wonderful panel and session, and I'm going to give the last word to Ken. Thank you.
Thank you, Rita Gail, and on behalf of IAS, we thank you, excellent panelists, for joining this session, and also the audience. The video recording will be available after the meeting on the conference platform and on the live streaming website. Please send us your ongoing questions via email at iasedu@iassociety.org, and we will try to answer anything that you may still have on your mind or we have not had a chance to respond today. We hope you're enjoying the IAS 2021 conference and we hope to connect with you again soon. Thank you very much and enjoy the conference.